Good afternoon, everybody. My name is Jean Fajadet. I'm a pleasure to work with Bruno Farah one more time. And we are really happy to contribute to this webinar PCR webinar session today. And we will focus today on the treatment of a really complex bifurcation lesion. And in addition, we will have to evaluate by intracoronary imaging using the OCT a lesion on the left main trunk. So we will be together for 45, 50 or around 60 minutes for the transmission. Do not hesitate if you have any question to send us. And Bruno will present you the case.
Yeah.
If we could have the PowerPoint slide.
So it's a 79-year-old patient. He's quite active. He has a previous history of... Est-ce que je peux avoir la diapo suivante?
Next.
So, next. So he has hypertension and non-insulin dependent diabetes. He has also an history of paroxysmal atrial fibrillation, and he's treated by anticoagulant agent, oral anticoagulant agent, mild aortic stenosis. And he has a previous history of peripheral arterial disease with treatment of the right femoral artery by endarterectomy. He was referred after recently developing some angina and exertion. The clinical examinations have not shown any particularity. The ECG have shown is in a sinusal rhythm actually. And on the transthoracic echo, good LV function, mild aortic stenosis with a mean gradient of 25. And on the thallium scintigraphy, an apical ischemia, 15% of ischemia, without any major LV dysfunction. On the blood test, what we can see, it has a mild anemia, but also some degree of chronic renal insufficiency with a clearance of creatinine that is around 46 milliliters per minute. The NT-proBNP is normal. When we look at the angiography, it's not clear, I think, on this view, but we will review that on the dynamic view. There is some, calcified plaque at the level of the left main. It doesn't seem to be something that is really severe, but it's there, and it's something that is a little bit, when we look at this, it seems to be something that maybe be a problem. Next. On this view, we can see that there is a tight stenosis at the level of the bifurcation of the LAD-Diagonal. This explains the result of the thallium scintigraphy. Next. We see this very short calcified lesion at the level of the bifurcation of the first diagonal branch, and it's a quite large diagonal branch. What we can say is the first diagonal branch has maybe some disease, but it's a short one. It's not a long disease. And the angulation between the LAD and the diagonal is around 40, 60 degrees. Yeah. More than 60 degrees.
Yeah.
Next. This is the view, the spider view. We can see the lesion, the eccentric lesion at the level of the bifurcation LAD diagonal. Next. And the right coronary artery is, diffusely calcified, but there is no major stenosis at this level. So to summarize, this is a 79-year-old patient, diabetic, quite active with some angina and documented apical ischemia at the thallium scintigraphy. And the angiography, we have seen a clear, severe lesion at the level of the bifurcation LAD diagonal. But there is an image at the level of the left main. We will review that on the angiography. Yeah. That is a little bit for us a concern. And finally, what we can discuss for this patient that is under oral anticoagulant, what would be the strategy for the dual antiplatelet therapy because of the need of oral anticoagulation. So what is our strategy? We are by transradial approach, 6 French. We will put two wire, one in the LAD and the first diagonal. We will first treat the LAD and the diagonal with stenting of the LAD and probably see if we can have a provisional strategy on the diagonal. This is the plan. If we need to put a second stent, I think that the angulation is quite favorable to do a tap. And finally, we will do after an OCT at the level of the left main to evaluate this lesion. But probably Now we can review the angiography and show to our colleague what is exactly this lesion looks like.
Yeah. So we know you can show us the previous view, and you will see on the previous view that particularly the image on the left main.
So here we see this you know, it's heterogeneous at the level of the left main.
Zoom in.
We can maybe zoom on this view at the level of the left main, and we can see this. It's like a calcified plaque, and it doesn't seem to be really severe. And if we rely to the result of the tensor thallium scintigraphy, normally it should not be a quite severe lesion, because there is no evidence of LV dysfunction and no very large lateral ischemia associated with the. But we see this image, and it's quite, you know, something that is concerning.
Yeah, there's something abnormal, but it's true that this is a left main, a very large left main, which is around 5 millimeter. So you have to be sure that there is no critical narrowing. It's calcified. Before the injection, you could see very well the calcification.
And once again, we see on this view that there is something at the level of the left main. At each time we look at this image, we will review this. We see the short lesion at the level of the bifurcation LAD diagonal.
And again, the left main,
Here, once again, we can see clearly here the bifurcation lesion.
Yeah. Calcified.
Calcified. Short, but calcified.
Yeah.
This is the spider view, and we see this eccentric plaque at the level of the left main on the left side of the left main. We see it's just in front of the bifurcation, or just before the bifurcation of the circumflex. We'll see also the eccentric plaque at the level of the LAD diagonal bifurcation.
Yeah.
Maybe
I think it's the last one.
The last one. We have this one.
This one also.
To see the angulation, but I think this we don't see any major information.
So what Bruno has already done is to place the guiding catheter via the right radial artery using a 6-French guiding, and now he placed 2 wires successfully in the LAD and the diagonal branch. You could see the wires.
The wire is in place. So the strategy is to do the treatment of the LAD diagonal bifurcation, trying to be provisional, and then to evaluate the left main by OCT. We can discuss how to evaluate this kind of image, if it's OCT, if it's IVUS, if it's FFR, we can discuss thereafter.
So what you can do is to treat the left main bifurcation lesion as we treat usually. Left main, sorry, the LAD diagonal bifurcation lesion, I will treat usually using balloon stents, provisional strategy, and if because there is no long lesion at the osteomotor-diagonal branch, we will use a provisional strategy, and if we need, we will move to the tap technique. And then after that, we will evaluate the result of this LAD PCI and the plaque on the left main. Okay. So we have the 2 wires.
Yeah.
Next, Bruno.
Next, now it's predilatation. I think it's even if it's short, and we have the impression that direct stenting could be feasible.
Yeah.
It's calcified, and I prefer to feel a little bit the resistance of the lesion, so I will use a 3010, a short one. We don't need a long balloon.
That's very important. You see, when you see the angiography on the cranial view also. The previous one, this one also, but this one, you see before the injection, you see the calcification. And that's what we said with Bruno every day to our fellows. It's when we are doing a diagnostic coronary angiography, first before injecting, at least we need to film 4 or 5 seconds before the injection. And you could see very well the calcification starting from the left main, along the proximal LAD, taking the bifurcation with the diagonal, and then distal to the septal, that is less calcified.
We can discuss if we cover also the second lesion.
3-0 short.
Yeah.
Is it 10? Okay.
Will you cover the second lesion, or will you just focus on the first one? This could be.
Or maybe we can focus on the first one in order to avoid a too long stent, because Imagine that we have to treat the left main. It could be a really long stenting area. So we will see. It's not too bad, distal.
Yeah.
Well, except if there is a dissection post PCI. C'est celui-là, hein? Ouais.
Yeah. I hope so. Normally, this one is the
Yeah.
BMW. So the wire, the BMW in the LAD, and the runs through in the.
The distality is here.
Yeah,
Okay.
here, okay. And the runs through for the diagonal. So let's see. It's the LAD.
We can just take a small test, just a gentle test, not too much contrast. He's diabetic.
Yeah.
Yeah. And the renal function, the GFR is less than 50. Yeah.
I think it's correct.
It's correct. It's good. So what you can do now is to open 6, 8, and then we will see.
Oh, you just slipped.
Yeah.
So
the problem,
short.
that's a problem of the very short balloon.
Yeah.
Sometimes it slips on along the wire.
And on the
So here we are not too bad. So Bruno will maintain the balloon in this position while I will
yeah, it's okay.
open. You
It's
can
better.
pull a little bit. I will open gently the balloon here.
Okay, this is better.
This is better. So we have 10 atmospheres with a...
Stop. Maybe we can advance a little bit now. Okay.
Here.
Here, yeah. Yeah. Now
One more time. 10 atmospheres, not necessary. We can film it, but the balloon looks well open.
Yeah.
Yeah, so you can deflate it. And then we will see how is the result.
Okay.
That's fine. Can take a view.
This is better.
It's good, on LAD, and there is no zoom in, s'il vous plaît. No dissection, and geographically, no dissection distal to the balloon inflation zone. There is a small dissection at the side of the bifurcation, and the patency of the diagonal is good.
Yeah.
So, next step.
Next step now is to stand the LED. We're pretty late. Maybe an 18 should be in length, should be okay, because we have to think about the 10 millimeter before the bifurcation in order to perform the pot. So, and the diameter, 3.0, and then we will take a 3.5 to do the pot.
Okay.
Okay?
Donc 3.0.
3.018.
So we take 3.018 millimeter stent. I'll explain Bruno. We will inflate the stent up to 14, no more than 14 atmosphere. Then we will post-dilate with a 3.5 balloon with a gel wire, and then we will see what you need to do for the diagonal. So there is a question coming from the audience. Can we decide for plaque modification with rotational atherectomy or AVL in calcified lesion on simple coronary artery disease, or do we need IVUS? So I will tell you what we are doing in routine practice. So with some years of experience, and what I said, first, we need a high quality of angiography. And if we have this kind of calcified lesion, what we see, it's not heavy calcified. It's quite a short lesion. And this lesion will be covered easily with an 18 millimeter stent. If there was a bifurcation, we will select certainly shorter stent. Here we have 18 because we anticipate the length of the pot. And in this particular case, we think that we can do using a balloon, standard balloon. Sometimes we use a non-compliant balloon, an NC balloon, in order to be able to increase the pressure up to 22, 24 atmospheres. In case of short lesion and undilatable lesion, very short, sometimes what we use it's a very high pressure balloon, OPN balloon, and you can go up to 35, 40 atmosphere. This is for short lesion. If this is not working for short lesion, there is certainly an indication for lithotripsy. And it's true that intravascular lithotripsy using the shockwave balloon can help you to open a discrete heavy calcified lesion. In the opposite, when we have a very long, diffuse calcified disease, we prefer to use the rotational atherectomy. And in this particular case, for the vessel which is around 3 to 3.5, we will start certainly with a 1.5 millimeter burr, and then followed by a balloon inflation and stent implantation. That's our philosophy. Yeah. And we do not use in routine for calcified lesion intravascular imaging. We will prefer to use it when you have a depth on the assessment of the severity of the lesion, like in this particular case for the left main, or when we have a depth in, the opening of the stent, if you have, residual narrowing within the stent, even after using high pressure balloon. That's our philosophy. So Bruno.
We will check in this view if we are correct regarding the left main.
Yeah.
Let's see. I think that probably it's okay. Huh?
Here is okay. Huh?
We are before the bifurcation.
But what we can do is to use the spider view. In spider view, that was very nice view.
Yeah.
In order to see the LED proximal to the bifurcation and the bifurcation. So we could
maybe
see something like that.
Yeah, that is correct. Okay.
Picture.
We are just before. Huh? It's okay.
I think it's okay.
Yeah.
Yeah, it's okay.
Yeah,
it's okay.
Okay.
We deliver.
Yeah.
In this view.
Yeah.
So 3-0.
14.
We can film it.
Yeah.
We have 12, 14 atmosphere.
Okay.
So not necessary to go for higher pressure in order to reduce the risk of dissection distal to the stent. And what we will do systematically without the use of intravascular imaging is to take a 3.5 short balloon in order to do the post-dilatation.
Because we are treating a bifurcation, and the diagonal is a quite large branch, at least 2.5, even 3.0. So normally the diameter proximal to the bifurcation.
Yeah, normally it's
at least 3.5.
3.5. Yeah. We can take a view, and I think that we select a 10 millimeter. Yeah. It could be 10, it could be 12, it could be 13.
Oh, it's okay. Huh?
It's okay now. It's okay.
I think it's 8, no?
It will be
8. It's 8.
This one is 8.
Okay.
And it will be important to place the balloon, of course, along the within the stent, along the proximal portion, proximal to the bifurcation, and just at the side of the bifurcation, in order to be sure that we open correctly the struts regarding to the diagonal. Tu as le... Hop, voilà. C'est bon. So we use this caudal view
in order to treat the proximal.
You want to look at the stent V's?
Yeah, maybe. If we can.
We are. Okay. We are ready. Stent V's?
Bon.
Could probably be okay.
I think we have to
proximal or?
Yeah, probably we are too proximal.
We'll see.
Yeah, it's clearly too proximal.
Yeah, it's too proximal. Huh?
Yeah, should be okay.
We can repeat the stent V's one more time. Stent V's is very useful. Stent V's or stent boost In this particular,
maybe we can pull back a little bit.
yes, a little bit of calcified lesion. So sometimes we have to take care of the position of the balloon, because by standard fluoroscopy, sometimes it's difficult to make the difference between the calcification and the wire of the stent, the thread of the stent.
14, 16.
So it's 14, 16 atmosphere proximal to the bifurcation.
Top.
What we can do now is to move maybe on the caudal, which was very good, and then the cranial.
Cranial,
yeah. But just to see the, where is it?
No, the down.
Yeah, I forget here.
Yes, you are quite close of the bifurcation. We look at the wire separation. I
think. It's not too. Okay, I try to separate two wires. Okay, here it's not too bad. We can take a view.
Yeah, it's quite. I think that maybe you can advance.
I can maybe advance a little bit in order to open. Here is okay.
Yeah.
Okay,
we'll check
one more inflation. Yeah. 16. Down.
Maybe we can go in the...
Now we can go in the cranial view. Here.
Okay.
It's correct.
Yeah. Maybe we are...
Well, it's okay.
It's okay, I think.
So, of course, there is a narrowing at the ostium.
Maybe we can come back on the caudal view to be sure that we have opened the proximal part of the stent.
Yeah.
Because it's there that we can have some trouble after. So let's be sure that we have well do the pot at the proximal part. Let's see. Maybe we can pull back a little bit the balloon and be sure to be proximal to the... I will say that it's around this part, but difficult.
Maybe it's too proximal, no?
Yeah, probably. Let's see here.
We can use again the stent vis.
Yeah. C'est bon?
Ready? It's correct. I think it's correct. We will see.
Due to the calcification, it's sometimes difficult. You see, we are just
1 millimeter too proximal, a little bit. So Bruno will push 1 millimeter. The balloon more distal. Here is okay. So 20 atmosphere.
Okay.
Now 3.5, 20 atmosphere here, proximal to the bifurcation.
I think it's correct.
Now we will remove the balloon and try to now place a third wire.
Yeah.
You need a third wire or 2 wires? Yes, I think it's easier.
It's easier with the third wire.
It's safer. Another question, where we should keep distal balloon marker for pot, just proximal the stained branch or storm, or across them? That's an important question. When you talk about the pot, the definition is a proximal optimization of the stent, proximal to the bifurcation. So you can place the distal marker really proximal to the bifurcation. But what we have seen since years, it's when you place the marker at the site of the bifurcation. In other words, when you open widely your stent with a large balloon, you open the struts, and that's for the recrossing of the wire. And to place a third wire, now the new wire in the diagonal, it's really more simple. So it's very important to first to perform the pot, first to be sure that the stent is correctly open against the artery wall, and second, because you open your cells, and this will facilitate the placement of the wire inside the diagonal. You see? You were in. No?
No, but I want to be in the LAD and to go backward.
Ah, okay.
I prefer to do. Okay, let's see in the maybe in the cranial view. I will be here. Yes, I cross, but
You cross, huh?
yeah, but normally it's better to be.
Yeah, normally the technique, and Bruno is absolutely right,
is to go in
is
the LED.
to place the wire in the mid LED and then pull back the wire slowly, take a little bit clockwise movement of the wire at the site of the ostium of the bifurcation, and then you push the wire. It's what's just done.
You know, it's the way we are sure maybe to be more chance to be in the distal struts doing that. So now I have to pull back the gel wire. I do it gently.
So here we have to take care of the guiding catheter when you are doing this, particularly in this particular patient, because of this lesion on the left main. So when you pull your gel wire from the diagonal, automatically the guiding will tend to intubate, to advance and intubate the left main. So if you have no lesion, it's okay. But in this particular case, what you have to do, we are doing, and Bruno did, it's to disengage a little bit, 1 centimeter, the guiding catheter for the left main, and you ring the pullback, the guiding will advance again inside. Okay.
So now we can maybe go with a 2.5 short balloon, 2.510.
Yeah. So now what to do for the 2.5, 2.0? I think 2.5 is what's a large diagonal.
It's a large diagonal, yeah.
It's a large diagonal, yeah. That's it.
Yeah.
Okay. It's a large diagonal, yeah.
Yeah.
Yeah, it's a large diagonal. 2.5.
2.510.
De 5.
De 5-10.
De 5-10. We can take a 10. It's not necessary to
because
take
it's quite short. Huh?
Yeah. If we take a longer, you can take a 15 millimeter balloon, but then we will have to do the kissing maybe with two long stents in the proximal LAD, and this is not necessary to do that.
So here there is, after that, if the result after balloon inflation is quite good, there is 2 options. First one is to do a standard kissing.
Yeah.
The second one is to do just a repot.
Bruno, question on the type of wire you used for the diagonal to recross the stent.
I use as a first intention, first step is to use the runs-through wire. It's the one that I use, like a workhorse to cross, the sail of a stent. And if I have some difficulty, then I move to sort of like a Fielder FC or more hydrophilic wire. So first step is the run-through wire. It's my workhorse wire, and then if I have some difficulty, I take some more, difficult one. Sorry.
No problem.
No. Okay. I need glasses and to do that. So okay, it's better.
Good.
Good.
Excellent.
Jean, what is your strategy here? What are you
No, normally I use the same wire, whole BMW wire or this kind of wire. But if I really fail, I move very, very quickly to run through wire or a Fielder FC. Yeah.
Sometimes it's not only the type of the wire, it's the curve that you put at the level of the wire that is important. Because here it's a quite large...
And the level, the quality of the post-dilatation. Yeah. So that's very, very important. So when you take a large balloon...
Okay,
here we are in.
Yeah.
We open or...
I think we can open here.
To see an angio? No, maybe just without...
Yeah. Okay, let's see.
Without injection. Yeah, we are really in the middle. This is 14 atmosphere.
I think it's okay. So
we can leave for
1 minute.
Yeah, 1 minute.
Then we will...
in order to really give to the balloon the chance to be successful. We know for experience that when you are doing long balloon inflation, the result, angiographic result, is a little bit better than when you are doing just 10 seconds. So when you are doing balloon with having in mind the strategy of provisional stenting, We have really to give to the balloon all the chances. And so it's the reason why we inflate at least 1 minute in the side branch. Of course, if the patient cannot tolerate, we will deflate. But if the patient can tolerate the balloon inflation, if there is no major ST changes on the baseline on the ECG, we can continue 1 minute, 2 minutes inflation. The position was perfect.
Yeah.
And you see that the selection of the quite a short balloon is enough.
Yeah, it's enough.
It's not necessary to take a longer one, because in this particular situation, really the lesion was located just at the ostium. It was a true bifurcation, a 1-1-1, but with a very short lesion at the ostium. It's totally different when we have a bifurcation with a long lesion on the side branch at the ostium and 1 or 2 millimeter. In this case, we know that the balloon could not do the job correctly. And so we do a quick opening of the side branch, and then we move to the tap very quickly, very fast.
Okay, maybe we can check.
Good. We remove it? You remove it? Yeah. It's correct. It's not too bad, huh?
Maybe I can remove fully the balloon.
Yeah.
See what's the result.
It's not too bad, huh?
Yeah. So the discussion is to do a standard kissing or just a report. Actually, there is no clear answer about this step. Yeah. I will say that here probably maybe we can just try to do a report with a 358 that we use. Yeah. Let me check.
Okay. When you want. Ready. Zoom.
Not so bad, huh?
No, it's not too bad. Not too bad, huh?
We see that the deformation of the stent a little bit. So we need to do
a pot again, to redo the pot. Could you do another question? Could you please explain about bend at wire tip for rewiring? A single bend is okay, or 2 bends primary?
Yeah. In general, I put 2 bends. And I think that it depends of the diameter of the artery. When you have a quite large artery like 3.5 or 4.0, probably you need to put 2 bends and quite large, because sometimes to cross toward the cells, you need to have some push from the opposite wall, and so you need to anticipate what will be the size of what would be the length of the wire from the opposite wall to the threads. That's why sometimes you need a quite large bend.
Yeah. That's very, very important. We cannot say that we are using the same bend for all the bifurcation. If you have a large proximal main vessel and the small side branch, it's true that when we will do what we don't have done, we will have the bend, quite a large bend like that. We will cross the bifurcation within the struts, and distal to the stent, we will remove, turning clockwise, and then take the diagonal, but with a large bend. In the opposite, if you have quite a diffuse disease, quite small vessel at the end, 3 millimeter for the main vessel in proximal, 2.5 in distality, 2.25 for the side branch. Here you could use a shorter bend. Sometimes, if there is a tortuosity proximal to the bifurcation, and this gives you sometimes the difficulty when you have a tortuosity proximal to the bifurcation, it's better to place 2 bends, a distal very short in order to take the ostium of the side branch, and a proximal one in order to negotiate the tortuosity.
So now, what's the next step, Jean? You will use a kissing, standard kissing, or repot?
Oh, we can use a kissing, no?
Kissing,
what do you think?
Okay.
Yeah,
okay.
We can use a kissing.
So the 2.5 and the 3.0 probably.
3.0 to 5.
3.0
Not necessary to take high pressure. We will use
the 3.010 and the 2.5 for the.
And around 6-8 atmosphere.
Yeah.
Le 2.5 on l'a. Hein?
Oui.
Il faut un 3.0.
Un 3.0, on l'avait aussi tout à l'heure, je crois. 3.010, on l'avait. Ouais, on n'a qu'à le prendre.
Okay, this one is 2.5 or 3? 2.5. So we start by the 2.5 that Bruno will place
on the
diagonal wire. So it's very important when we are working to have a clean table. That's very important. And all the time to really identify the two wires. You could identify placing a torquer on it, or just a wet gauze on the wire. But really, it's important to identify what we need is to avoid, the twisting of the wire. When you leave your two wires parallel on the table, and when you are manipulating the balloon, removing, advancing, doing the kissing, sometimes you can have the twist of the wire. And if you have the twist of the wire, sometimes very, very difficult to recross the struts with the balloon. And sometimes we have to remove all the material.
Let's see now, it's coming.
So,
okay,
here you are. So you see
the
technique is to place the marker distal to the bifurcation,
yeah.
the distal marker a little bit distal to the bifurcation inside the diagonal,
Yeah.
and then it should be easier to remove it, to reposition the balloon.
This is a 3010, huh?
30 by 10.
So the problem is my eyes.
No problem. Very good. Ne bougez pas, monsieur.
Okay.
Okay, I take the wire. The LAD wire is
this one.
Is this no
the green one?
The other one. Huh?
Yeah, it's the BMW.
Okay.
Okay, I think it's correct.
Very good. Okay. So now what you can do is to remove a little bit the balloon, the diagonal balloon.
This is the one diagonal you have it?
Yeah, I have the diagonal. Okay, maybe. This is good, huh?
I can pull back a little
bit. Pull back also the LAD.
Yeah.
Excellent.
Excellent. Okay.
We can. So inflate first the diagonal and then the LAD.
We see that the angulation is
we can film. Yeah, it's close 90 degrees. Eh? It's around 75 degrees, which is good. Eh? So we have 8 atmosphere, 10 atmosphere on both. And here for, we hope that the patient could tolerate 40 minutes, but it's moving a little bit.
So maybe we can deflate. Okay.
Okay, we deflate. Attention, tenez-lui les jambes.
Okay. It's okay. So it's symptomatic.
Aussi d'ombre, là. Alors.
Okay.
Good.
I will remove both balloons. If we want to have a good injection, it's better to remove both balloons.
Particularly within the 6 French guiding catheter. Sometimes it's better to remove the balloon, leave the wire in place, and then have the good angio. If not, this is very difficult. Good.
Okay. I think it's
correct. Yeah, it's correct.
Think the result at the level of
yeah. Beautiful.
Yeah.
You want to do another view or
maybe we can
the
go
caudal?
The caudal, yeah.
Yeah.
And what we can do after is to remove the diagonal wire.
Attention, il est en train de bouger là.
And we will evaluate the.
Attention, là, il se barre là.
Okay. We just have to take his hand. Attends, on va le laisser ça.
Ouais.
So. Ok.
Allez, prenez-lui les bras, il faut l'endormir un peu. Ouais.
C'est bon, Hélène? On va te laisser le.
Okay, everything is fine.
You know, what we can see is during the inflation, there was a clear ST depression. That
yeah. And you feel it, and a little bit moving on the table.
C'est bon pour toi?
Ça va? Tu vois, là, il est en train de...
C'est le bras droit, c'est le bras gauche. C'est bon pour vous?
Vas-y. OK. Alors.
OK.
Hop.
OK, we have it.
It's not too bad.
Sur un côté.
Ouais, je sais.
C'est bon pour vous? C'est bon?
C'est bon, on y va.
OK.
Table down, on peut y aller.
No, it's
Beautiful.
beautiful. Yeah, I think it's now it's the lesion of the bifurcation
No,
diagonal
it's beautiful.
is treated.
But you see, now what we see at the beginning during the clinical presentation of the patient, we have to evaluate this plaque on the left main, just proximal to the bifurcation of the circumflex.
Probably we can remove the diagonal branch.
I think so. I think so.
We can now focus on the
absolutely. We will leave the LED wire in the distal LED. We remove the diagonal branch, and now we will advance the OCT probe in order to take some images and to appreciate first the result of the stenting in LED, and second, to appreciate the severity of this lesion and the anatomical characteristics of this lesion of the left main.
Yeah. So we have the OCT probe. Okay.
Voilà.
So it could be an evaluation by IVUS. It could be also discussing to do FFR. It's evaluation of the left main is sometimes difficult just by angiography, and some tools like the intracoronary imaging or the physiology test would be something very helpful.
So what we will have to do is to disengage a little bit the guiding catheter, not too much to be sure to have a good angio injection, but in order to see not only the plaque of the mid left main, but also the origin of the left main. Okay, the catheter is flushed. Now we have the OCT probe.
Parfait. Amène-moi un petit peu là, voilà, parfait. J'en ai encore besoin d'un peu plus.
C'est bon?
Ok.
Tu l'as là?
Il arrive. Now it's arriving.
Vous l'avez purgé? C'est bon. Ouais, on peut le faire manuel, hein. Enfin, comme tu veux, comme tu veux.
I think we can be there. We are quite down now. I have
tu as l'injecteur prêt? On va injecteur.
So I have to disengage a little bit.
Yeah, that's a difficulty. So we will test a little bit to be sure that the guiding is inside the left main and not outside.
Okay. Yeah, it's better. Huh?
I think it's okay.
Okay.
And here we could see
Okay, I think it's good, no?
I think it's okay.
Okay.
So we have to
connect the injector.
Connect the line of the injector. No bubbles.
It's okay.
Ready.
So I have to open. We have to go in the OCT. On peut mettre l'OCT.
Yeah. C'est bon là. Je crois.
Ok.
Ready.
Activer le retrait. We have to.
C'est bon, ça va partir. Tu peux y aller.
Allez-y, injectez. Ah non, attendez, stop.
Stop.
This was not tightened.
Yeah.
That's why. On va le refaire.
Are you still inside?
Yeah. Sorry. It's my fault.
No problem.
Okay. Okay, I have to come back here. We will redo the. Probably. Okay, this is better. Okay.
I think it's okay here.
I will. It's
ready.
Okay, we are ready. Oh, attendez, you have to wait. Attendez. Ok.
Okay.
Activez le retrait. Allez-y.
Vas-y. Difficult.
Yeah.
We'll see. Maybe we need a second one.
Yeah. Maybe I was a little bit too disengaged. Huh?
Yeah.
This is the
stent
is well.
We can evaluate the stent, but
after it's quite.
After we need to engage a little bit more. Yeah. We know at the beginning that this will be the difficulty because we cannot push too distal the guiding,
Okay, this is
in order to leave the, what we can do maybe is the test from where? From here?
here.
Here.
Okay. You can do that.
From
Disengage this. Okay.
Yeah, to be sure that we are in.
Not.
Now you see,
not enough.
we have to engage a little bit more.
This is probably better, no?
I
Wait.
can.
Can you test?
Yeah.
Yeah.
Here is better.
So I will re-advance
Definitely.
the OCT probe. Sorry. Okay. Okay, here it's better. Okay.
Ok.
Vous êtes
Attends,
prête,
c'est le
Sabine?
bon? Ouais. Attends. Hein. C'est celui-ci?
Ouais.
L'OCT?
Ouais. Oui, c'est ça.
Parfait.
Non, c'est bon.
Non, c'est bon.
On va refaire un enregistrement. Donc, activer le retrait, c'est bon? Allez-y. It should be better.
Yeah, much better. Good.
Good. Let's
Now
see
we have time to look at the images. Vous pouvez mettre l'OCT en grand sur l'écran.
This is the stent. It's well posed. We see the bifurcation.
Yeah.
And what's this image? It's something in. It seems to have a severe
Yeah,
lesion
yeah,
inside
yeah,
the left main.
yeah.
Just before the guiding, we have
Yes.
like I don't know. We can review the. Okay. This is the bifurcation LAD diagonal. We are close.
Stop. Do it slowly. Keep it frame by frame. We can look at the stent position, which is okay. Eh?
Yeah.
Go to the distality to be sure that we have no dissection distal to the stent. Just a little bit. There's something here, but this is really acceptable. Okay, come back slowly.
Continue.
We have to see now the opening of the diagonal. The ostium of the diagonal coming here.
And we see it.
You see it's a very large opening of the diagonal at 7 o'clock, 8 o'clock. Very good. Excellent. And now we continue proximal. Stent is okay, is well open.
And now it's the distality
And
of the
now
left main, no?
This is...
yeah, it's the plaque. It's the calcium.
There is a plaque. Continue.
It's
And here is it. You see? Here is...
I think that definitively there is a severe lesion here. Huh, John, what did you say?
Yeah, on the cross-sectional view and on the longitudinal view, you could see very well the plaque. Here, look at that. Wow.
Yeah, I think it's difficult to leave this.
No, we cannot see. We cannot leave this. Come back.
Okay, go back.
Come back. Go to the...
Okay. And see, once again, it's really not a nice image inside the left main. The lumen
Continue.
we see, it's less than 6 millimeters.
But this is still
the left main, yeah.
Continue.
Continue, and we will arrive inside.
Here we are.
Yeah.
That was a stent, no?
Yeah.
Here, look at that.
Yeah, it's really... Oof. Very severe.
Yeah, continue.
And we will arrive inside the guiding. So
that's the left main, and it was the stent, yeah. And there is no... the stent is well opposed in proximal with a 3.5 balloon.
Yeah.
But look at this image. Here in the tube. So now move distally. Slowly. Look at the left main here. Good. Yeah. Wow.
So here I will say that we have to put an additional stent at the level of the left main.
Here we will, this is the origin of the stent. Can we see the bifurcation with the circumflex? Pull back. It is here, I think.
Yeah.
So why here? Wow.
Okay.
Okay, so now the strategy is to treat the left main.
So we have to.
It should be certainly from close to the ostium to the other stent.
Yeah. It's better to be. Yeah.
Concerning the size, 3.5, 4?
I think that 4.0 could be okay. I think,
Yeah.
and because we'll move to 5.0 at the end, I
Okay.
think that,
So now the length?
the length, I think it's from 32 to 40, at least 20.
40,
Yeah.
to 50.
It's 40 to
Can we
50,
see again
yeah.
the angio? Maybe like that.
Yeah. This is the, okay,
Yeah.
okay. We see the opening here of the diagonal.
Yeah.
And this is the, okay. Okay, okay. Come back. We will see the opening of the diagonal on the left side.
Yeah.
Here.
Here.
Yeah, here. We see the strut that is pushed.
And then the struts.
Yeah. Okay. Okay, okay, okay.
Huh. Impressive. Here is coming.
Yeah.
Here.
Yeah.
Very curious. Huh?
Very curious, yes.
Okay. So, free row, and now look at the size of the NRAO.
Okay.
Just to look at the size of the
LAD and
LAD.
we can move on. There was a question, sorry, because we were
Sorry.
focusing on the image of the OCT. And okay, I will read the question because for me, so there was a question about maybe OCT should precede LED stenting. In fact, we were not sure that the OCT probe will cross due to the severity of the calcification of the LAD diagonal. That's why we decide to first read the LAD diagonal, because we were not sure that the OCT probe can cross this quiet lesion. It was 2 stent on the LAD and the left main with 1 stent, and then 2 provisional 2, yes. 2 stent LAD and the left main with 1 stent, and then to do 2 provisional T bifurcation. That's a possibility. The only concern is that at the level of the left main, if you use a 3.0 millimeter diameter stent, you will never achieve 5.0 millimeter diameter. So I think that here, if you want to do with only 1 stent the left main and the LAD diagonal bifurcation, then you need a 3.5 at least. And I will say that here I will prefer to use 2 separate stents in order to be sure that at the level of the left main I could achieve a 5.0 millimeter diameter. So that's why here we can use a 4.0 at the level of the left main in order to go to 5.0 without any problem.
So what we can do is in order to measure. So we have the OCT measurement, but you could also approach a new wire.
Yeah.
Place first in LAD,
and
measure.
Then,
and then place this wire in the OM branch in order to protect the OM branch, which is diseased there, the ostium. But
comme guide encore un run-through, il vous en reste un?
ouais.
Vous y en a pas un sur
In order to see with the wire, the length.
On en a.
I think we need maybe 28 or something like that. Close to 30. Tiens.
Ok. Ça fait une... Oui.
Non, j'ai pas fait. Hein.
Il y était. Ah oui, c'est tout à l'heure.
C'est nouveau?
Non, c'est l'ancien.
Ah bon. Good. Donc maintenant, il faut la scopie, fluoroscopie.
This is 30, and we are inside the stent. Huh? Let's see. We don't need to inject it, no?
And then I inject just at the end, because if you pull the guiding, maybe in order to take the ostium, look, we need 28 or...
Yeah, probably 28 should be very comfortable, no?
Yeah, or
26, I think. We have 26 probably. What I will try to go is to
26.
I'm in the marginal branch?
Yeah.
No, not yet.
It's a sort of ramus branch, so
this is
small one.
I am in.
Okay. Very good. So 4.0.
4.0, I think, yeah?
4.0, 26.
4.026.
I think it should be enough, 26. Yeah.
What we should avoid is to go with the stent to distal and to go on the bifurcation LAD diagonal. Yeah.
No, yeah.
26 should be okay, I think.
Yeah, because we have to cover the ostium.
Yeah.
If we decide to treat the left main, we have to start from the ostium. Merci.
Okay.
It's true that the lesion is on the left main is more severe than what we have seen on the angio. Okay, so here is not too bad.
I think
Difficult.
okay, because of the previous stent. Okay, let's see. Probably I'm not crossing the first stent. Okay, let me check. Okay, this is correct.
Yeah, now you can pull back.
And I will disengage the guiding.
And disengage the guiding, pushing on the wire.
Okay. Sorry, I'm too
No,
distal.
but yeah, go on. You have time. Okay. Because it's really precise. Okay, we can take a view of that.
Okay, let's see. Okay.
Very good.
Seems okay. Maybe we can go LAO to see if we cover the ostium. We don't see here clearly the origin of the left main.
We can go a cranial view like that.
Or maybe see less cranial. Let's see.
Yeah.
No.
No.
Probably you are right.
Maybe like that.
Yeah.
Well, it depends on the anatomy of the patient.
Yeah, that is better.
Here is better. Yeah. We can take a view here.
Okay. This is correct. Huh?
Oh, it's correct. Yeah.
Correct. I think that here we clear.
Okay, we go.
We can go to 4, 6,
8, 10.
Okay, stop maybe. And
we have 12.
We can.
Now
deflate.
we look at the position here.
Stop.
Looks good.
We will
and now
back.
What we will do with the 4-0, we will remove a little bit the balloon inside the aorta. We will place the proximal marker inside the aorta.
Like this.
Here. And then we take higher pressure. So this is 4-0.
Yeah.
And we will go up to
20 or something like that.
20. We can go. Here is 20, 21 atmosphere.
And we are in the left main, not touching the bifurcation. So that's okay.
And you see the distal marker is at crossing just the OM branch, the OM wire.
So now it's time to.
Good.
Okay, let's give time to.
So it takes time to deflate.
Deflate. So after we do the pot, because 4-0 is probably not enough for this left main, and probably we need a 5-0.
Oh yeah, because when you look at the initial baseline angiography, you have the diagonal, which was 2.5, LAD, which was 3.5, plus OM branch, plus the distal circ. So definitely we are close to 5 millimeter for the left main.
So let's see.
Attends. C'est bon.
This is okay, huh?
This is correct, but we are 4.3 after the post-dilatation, and if we can inflate with a 5 millimeter, it should be okay. 5-0, ballon. Ça peut être aux environs de 15, il n'y a pas de problème.
Ah non, 5-0, 12, très bien.
12, c'est bon. What about the wire? You want to remove the...
No, I think for the moment...
we can leave it,
We can leave it. It's not an issue. The diagonal is still open. The circumflex, sorry, is quite open.
At present time, it's okay. There was no lesion at the origin. There is a lesion at the origin of the OM branch, but the origin of the left circumflex artery was okay.
Yeah, okay. So I think that we can...
we can accept that,
for the moment. C'est bon?
Ouais. Tu as le guide?
C'est toi qui l'as, je pense.
Vas-y. Okay.
Okay, so I pull back on the guide. Okay, that's okay.
Maybe
So here we need to be
the web.
cautious advancing.
Can remove the wire of the
Okay,
little bit of LED. Yeah,
yeah, I
it's
think.
really distant.
Okay, this is better.
Yeah.
Okay.
Okay,
Here,
we are.
I think that here we see the separation of the wire. I think it's okay here. I think it's correct.
We go.
Yep.
So 5 millimeter. This is 8 atmosphere, 10, 12.
12, 14, I think.
Yeah, 14 atmosphere now. Can take a view.
Stop.
Very good.
We can deflate because probably will be, yeah. Maybe we can.
What you can do is pull back at the balloon, remove the balloon, and place balloon inflation
here
at the ostium and a little bit inside the aorta. Really?
Like this.
Okay, we go. 16, 18. To be sure that
the stent is well open, the ostium. I think it's correct.
Okay.
So what we can do now is to remove with time the, like this, in order to avoid any deep engagement of the guiding at the level of the tip of the left main. Okay, like this, it's okay. We cannot test with the 5-0 inside of. Probably we will check now the results and maybe remove the. If the result is good, is remove the jail wire. Yeah, I think it's right.
So what you can do is to remove the jail wire in order to be able to engage the tip of the guiding catheter inside the left main.
So what I have done is I push simultaneously on the non-jail wire in order to counterbalance maybe the risk of engagement. Okay?
We are ready. Very good.
Nice.
And the circumflex is open.
It's open. I think that we don't need to do something.
No, because the balloon was 5-0, so the struts are really open. And now we have a really correct. We can take another view, maybe on the caudal view here. In spider view. So we will appreciate the origin of the circumflex. But again, it was not a big vessel, so it's okay. Very good, excellent,
I think it's okay.
Excellent. And the OM branch was like that, but we decided at the beginning to do that.
It's a 90 degrees angulation, so I think we can tolerate this. The level at the left main now is a quite nice opening.
Oh yeah, sure.
I think that we don't need to do a final OCT here because the result angiographically is very nice. We use a 5-0 up to 16 atmosphere, so the stent is really nicely deployed. And we will maybe spare a little bit of contrast. So probably we can remove the wire.
I think so.
And do a final control. Here in this view. Okay.
Ready.
No, it's very nice. Very, very nice. And we can control the LAD-Diagonal.
LAD-Diagonal in cranial. I'm ready.
No, this is okay.
It's perfect.
Perfect. Huh?
Okay.
Okay.
Bruno.
So I think that this is the final angiographic view. I think that we treated this was the goal of this case was first to treat the LAD bifurcation diagonal lesion. The intent is to be provisional because there was a quite short lesion, and so that's what we have done. We do the standard steps using a 3.0 millimeter diameter stent for the LAD, doing a pot with a 3.5 due to the large diagonal. The result was good after treatment of the ostium of the diagonal just by balloon. So we finish by kissing, but we can discuss to do just one report. Then the second step and the second question of this live was to integrate by OCT the degree of severity of the left main. This was not clear by angiography. There was this image that was something that was concerning, and clearly by OCT it was a quite severe lesion. And remember that the patient has a thallium scintigraphy before the angio. This demonstrates only some apical ischemia. And though it was not clear just by the thallium scintigraphy that we have to treat the left main, but I think that the OCT image was quite demonstrating. So the third step was to treat the left main with the standard provisional strategy and doing a pot with a quite large balloon at the left end of the left main. And the final angiographic result was quite good. So if we have time, we can discuss.
If you have any question,
we can
do
discuss
not hesitate.
It
should be a pleasure for us to.
Maybe we can move to the room and.
Yeah.
If there is some question. Okay.
Okay. So we move to the side room in order to answer to your questions.
So I don't know if there is additional question. Maybe before some question, we can discuss about the strategy for the APT, because this patient is under oral anticoagulant therapy, is under
atrial fibrillation,
rivaroxaban for this atrial paroxysmal fibrillation, and you need to continue this treatment. So I think that this patient have been treated with 2 stents, but 2 quite large stents. Is stable, and so probably we can treat this patient with Plavix just for aspirin and Plavix for 1 month, I think, and then moving to aspirin alone. The good news is that we use also the Medtronic Resolutonic stent, and recently there is some data saying that we can safely stop the dual anti-therapy after 1 month. So I think that clearly for this patient we can be comfortable using the DAPT regimen for just 1 month, continuing after 1 month Plavix and the NOAC therapy. That will be our strategy.
It's true that this strategy is sometimes variable from patient to patient. It depends, of course, of the risk of bleeding. And if you have the same patient like him, but with 85 years old, this will be really difficult. Even for 1 month, we have the triple antiplatelet therapy, but we will take the risk. And in the opposite, if you have a younger patient, you can move for 3 months. It's really and second, it depends on the result that you get from the PCI, the number of stents implanted, the length of the stent implanted. It's different if you have what we have done today. In other words, only 2 stents in a very large vessel, 5 millimeter, and then 4 millimeter for the proximal LAD, with a good result. No additional stent at the side at the ostium of the diagonal branch. So we have 2 stents, not too long, in a very large vessel. And it's true that we can really, in this particular case, reduce to 1 month of triple regimen therapy. The difficulty is when you have a complex bifurcation with overlap stent, with I hesitate all the time.
Remember, this is a diabetic patient, so probably the thrombotic risk is a bit higher. But here, hopefully, we can treat this with only 2 stents, 2 last generation stent that we know that even for this last generation stent, even 1 month of DAPT is quite satisfying. So I think that here we are quite comfortable.
But this is a really interesting patient, and with, of course, the anatomy and the clinical presentation of the patient. Diabetic, paroxysmal atrial fibrillation, impaired left ventricle renal function. Again, the GFR was 46, I think. It was less than 50 ml. So due to all these things, we have to take care now during the next 24 hours. Diabetic, receive some amount of contrast, non-negligible amount of contrast media. And with this baseline creatinine clearance, So we will need to have at least for 24 hours full optimal hydration and control the renal function tomorrow and maybe the day after tomorrow. We have really to take care of that.
There's a question, Jean. Was it acceptable to stop after the pot, after LAD stenting and pot, without fenestrating stent to diagonal? I think that the angiographic view showed that there was some degree of narrowing at the level of the ostium of the diagonal. It was quite a large branch. Probably if it was a less important branch, we will be more conservative. Here, I think that the question is very good because probably there is some of our colleagues will stop after the pot because the result seems acceptable. There is not really a lot of rationale to do the kissing, except that it was a quite large branch, and it's something that sometimes favor to do the kissing.
Yeah, I fully agree. It's really the decision is really related to, well, of course, the result that you obtain after the stent implantation and the pot, and second, the territory of this side branch, which is in this case a very large side branch. So I think that in this case it's better to perform kissing balloon. We have no, you cannot compare a single versus the kissing balloon. But it depends really of the size of the side branch, the angiographic result that we obtain after the stent implantation in the main branch, and the territory of this side branch.
And your personal experience, because sometimes you have not done the kissing and the patient come back with some angina. So the next step, the next time you will do the kissing. So sometimes the personal experience may change a little bit the game. So maybe I think that if there is no more question, you can conclude, Jean.
Yeah, well, I think it was a really interesting patient, particularly first concerning the clinical presentation. It's quite an high-risk patient for, complication for PCI, particularly in this diabetic. Look at the renal function, and we will take care of really carefully of hydration during the next 24 hours. And then concerning the procedure, there was what you said at the opening of this webinar, really the two parts. The first was the focusing of the treatment of a bifurcation lesion, which was a severe lesion on the proximal LAD, including a large diagonal branch. And it was a true bifurcation lesion, 1-1-1, but fortunately with a short, discrete severe lesion at the ostium of the diagonal and not a long disease. So we could do it by a stent implantation in a main vessel, followed by the pot, followed by the kissing, and at the end, the result was good. That's what the first part. The second part was the evaluation of the left main disease. And I was really impressed one more time by the severity of what we saw on the image by OCT compared to the initial anatomy on the angio. We saw at the initial anatomy that there was something.
We were concerned.
And we say, I remember,
at the image,
I remember at least 50%, but it was more. It was definitely more. And I think it was the right option to assess the severity of the disease, look at the length of this disease in the left main, and then to treat quite simply with the stent implantation using a large stent, which was a 4 millimeter, opening of the stent after pulling the balloon inside the left main at 20 atmosphere. So we were at 4.3, 4.4 millimeter. And then we finished by a 5 millimeter balloon, because when you have this kind of distribution, a big LAD, a big diagonal, a large OM branch, and a circumflex, all the time you have at least 5 millimeter diameter for the left main. Okay, I think it was really interesting.
Yeah.
Again,
thank you.
It was a pleasure with Bruno and myself to transmit this procedure for this webinar. Thank you to Medtronic to support this educational case. And I hope that this case was interesting, and you learn something. But we learn every time, and when we are doing something, procedure, and this will be useful for your job in daily work in your cath lab.
Thank you.
Bye bye. Thank you.